Bismillah Rahman Rahim. Today we will start with the system of GIT. And you know GIT starts from the oral cavity to the anal canal. And in the oral cavity, we will study about the inflammatory lesions and neoplastic lesions. But before we go on to the specific inflammations and tumors of the oral cavity, just a few words about the caries. And the caries is demineralization of the dentine and enamel of the tooth. Then gingivitis is quite common. It is inflammation of the gingiva. Now there may be some reactive tumor-like lesions which are inflammatory in nature, but they can produce tumor-like lesions and they may clinically mimic neoplasms. Irritation fibroma, peripheral ossifying fibroma, pyogenic granuloma, peripheral giant cell granuloma, and traumatic and aphthous ulcers. Among these, there are two main common diseases. One is the aphthous ulcers and pyogenic granuloma. Aphthous ulcers, they are recurrent superficial erosions occurring in the oral cavity, especially in the children and immunocompromised patients. They may be single, multiple, or hyperemic ulcers. They are quite painful and the cause is unknown. They are often associated with the GIT diseases like celiac disease and inflammatory bowel disease. Then is the pyogenic granuloma. So this is also a benign condition and it clinically presents with the raised red papular thickening or sometimes a tumor. And under the microscope, there are small blood vessels, anastomosing capillary-sized blood vessels. And there are some neutrophils also. And as the name indicates, pyogenic granuloma, there are neutrophils and the microscopic appearances, they resemble granulation tissue. So this pyogenic granuloma is often seen in pregnant females and it is also called a pregnancy tumor. So that is about the pyogenic granuloma. So then is the infections of the oral cavity. So quite common infections, they are viral. And herpes simplex virus infection is quite common. It is caused by herpes simplex virus type 1 and sometimes also type 2, that is genital herpes. And they present with mild vesicles and under the microscope there is intercellular edema and intracellular edema. And the epithelial cells, they contain intranuclear viral inclusions. And in sometimes there may be multinucleate giant cells of the squamous cells. And these giant cells, they are detected in the vesicles fluid by staining with Giemsa stain, and the test which we carry out is called Zank test. So this is a specific test for the diagnosis of herpes simplex infection, Zank test. And second infection of the oral cavity is the most common fungal infections, that is Candida albicans infection, oral candidiasis. It is also called thrush, and it is seen in diabetic patients or patients who are immunocompromised, receiving immunotherapy, chemotherapy, diabetics, and other transplant recipients or patients taking antibiotics. Then sometimes you may come across deep fungal infections like histoplasmosis and aspergillosis. So that is about the infections. Then there are certain precancerous lesions of the oral cavity which predispose to the development of carcinoma of the oral cavity. And hairy leukoplakia and erythroplakia, they are two precancerous lesions. Leukoplakia is defined as a white, fluffy, hyperkeratotic thickenings, and that cannot be scraped off and cannot be characterized clinically or pathologically as any other disease, that is leukoplakia. So definition of leukoplakia is a white patch or plaque that cannot be scraped off and cannot be characterized clinically but pathologically as any other disease. And erythroplakia is, as the name indicates, erythro means red. So it appears as red, velvety, eroded area. So these are the two precancerous conditions of the oral cavity, leukoplakia and erythroplakia. And under the microscope, there is hyperparakeratosis, acanthosis, and with balloon cells in the spinous layer. So hairy leukoplakia is caused by Epstein-Barr virus, which is the cause of infectious mononucleosis and other tumors of the oral cavity, like nasopharyngeal carcinoma and Burkitt's lymphoma. So this is the gross appearance of erythroplakia, red velvety thickenings of the mucosa of the oral cavity. And this is leukoplakia. So you can see the white appearance, fluffy white patch or black that cannot be scraped and that cannot be characterized by any other disease. And leukoplakia and erythroplakia, they show hyperkeratosis and acanthosis. Acanthosis is increase in the number of layers of the stratified squamous epithelium, and there are different morphologic features of dysplasia, starting from mild, moderate, and severe. So dysplasia is altered pattern of growth, and when dysplasia involves the full thickness of the epithelium, that we call it as carcinoma in situ. There is no invasion of the basement membrane in carcinoma in situ, but cytologically, morphologically, the cells are malignant in nature, but they don't invade the basement membrane. And in the subepithelium, there may be inflammation. And in case of erythroplasia or erythroplakia, there are vascular dilatation. So that is about the precancerous lesions of the oral cavity, leukoplakia and erythroplakia. So then is the squamous cell carcinoma of the oral cavity, or head and neck squamous cell carcinoma. So they are the most common cancers of the head and neck or oral cavity. That is squamous cell carcinoma, 95% of the cancers. Less commonly, there may be adenocarcinomas of the salivary glands and squamous cell carcinoma of head neck region, that is oral cavity. Squamous cell carcinoma is an aggressive malignant tumor. It is the sixth most common malignancy in the world. And in these patients, there is a chance of second primary tumor formation, and this rate is about 3 to 7%. So this slide shows the locations of the squamous cell carcinoma. So location of squamous cell carcinoma, it may occur in the floor of the mouth, base of the tongue, hard palate, peritonsillar area. So these are the common sites of the squamous cell carcinoma. So what is the pathogenesis of squamous cell carcinoma? It is multifactorial. Smoked tobacco juice, alcohol consumption. So they are the chemical carcinogens which cause development of squamous cell carcinoma. Then there are oncogenic variants of human papilloma virus, especially the HPV-16. So this is also a cause of oral squamous cell carcinoma, like carcinoma of cervix. As you know that carcinoma cervix is also caused by high risk groups of human papilloma virus, like HPV-16 and 18. Then there may be family history. Patients having family history, they are more likely to develop carcinoma of the oral cavity. And sometimes patients with inherited genomic instability syndromes, like Li-from-Anne syndrome, in which there is a defect of DNA repair. So these patients, they are also more likely to develop carcinoma of oral cavity. So use of pan, or betel nuts, and they are also causative factor in development of squamous cell carcinoma of the oral cavity. So there are different molecular markers of the squamous cell carcinoma. Tumor suppressive gene P53, and then P63 Notch1 pathway. Similarly, P16, which is a cyclin-dependent kinase inhibitor, and also retinoblastoma gene. So these tumor suppressive genes, they are mutated in the molecular biology of squamous cell carcinoma. So this figure, you can see that in the normal epithelium of the oral cavity, there are no known genetic alterations. And when there is P16 mutations, then there is hyperkeratosis. And subsequently, P53 mutations, they lead to mild or moderate dysplasia. And then there is the cyclin D mutations. So there will be severe dysplasia, that is carcinoma in situ, and ultimately there is squamous cell carcinoma. So initially hyperplasia, hyperkeratosis, then mild to moderate dysplasia, then with the passage of time severe dysplasia or carcinoma in situ, and ultimately invasive squamous cell carcinoma. As I said, the squamous cell carcinoma of oral cavity, head and neck region, it is an aggressive tumor, and as there is no screening test like carcinoma cervix, so these patients, they often present late in their clinical presentation. So when the patients present, the tumor is quite advanced and they are quite aggressive as there are no screening tests. So morphology of squamous cell carcinoma, grossly there will be raised irregular firm pearly plaque which may be ulcerated, and sometimes there may be fungating and protruding mass formation. And under the microscope, you will see dysplastic lesions, that is carcinoma in situ, along with well to poorly differentiated squamous cell carcinoma. So all the grades, that is grade 1, 2, 3, they may be seen. Squamous cell carcinoma may be well differentiated, it may be moderately differentiated, or it may be poorly differentiated or undifferentiated. So this figure is a well differentiated squamous cell carcinoma. You can see the keratin in this diagram, and these are the malignant cells, squamous cells. And so when you see keratin and intercellular bridges, so that is grade 1 squamous cell carcinoma. In this diagram, you can see the intercellular bridges. So these two characteristics of squamous cells, that is, one is cytokeratin and other is intercellular bridges. When both are present, we label it as grade 1 or well differentiated squamous cell carcinoma. As the tumor becomes less differentiated, the intercellular bridges, they cannot be appreciated, and cytokeratin is also not seen. So depending on differentiation, we may see cytokeratin and intercellular bridges, and then when the tumor is anaplastic or undifferentiated, there are sheets of undifferentiated cells. So that is about the squamous cell carcinoma of oral cavity, and some inflammatory lesions like viral or fungal infections. So this is for the first lecture. Okay, thank you.